Welcome, everyone. A special welcome to those online, as well as everyone here in the room. So we are here for part 2 of Stories of Our Faculty to introduce, especially those of you who are newer to PFRH, to some of the passions that our faculty have and what brings us here to Wolf Street or other locations on campus every day. We do have one announcement, which is a congratulations to the Fayette team from yesterday's trivia conference. So a round of applause. Mary Alice has shared that the victory photos are already posted on social media, as well as the bulletin board outside of her office. So for anyone who couldn't participate, talk to anyone on the Fayette team, but I think they're very pleased with themselves. But it was a lot of fun. So thanks to the many in PFRH who helped organize. So we're going to continue with our stories of the faculty today. And while we encourage everyone to come in person to noon seminar, we know that's not always possible. Folks are traveling, maybe in between other meetings. And so our first speaker today on faculty is going to be Tamar Mendelson. So welcome, Tamar.
Thank you so much. Hi, everybody, and welcome. I'm sorry I can't be there with you in person today, but glad I can join. So I'm going to tell a story about how I got started doing work on an intervention program for young people that I'm still working on today. So I came to Hopkins in 2006, a long time ago, and I actually came to join the Department of Mental Health. But I was lucky to get connected early on with the Center for Adolescent Health in PopFam. And at that time, the center was partnered with an organization called the Youth Opportunity Center, or the YO Center in Baltimore, which serves young people who left high school and are working toward a GED or getting job training. And the YO Center had identified mental health concerns as a big issue for their members that often got in the way of young people actually being able to complete their goals at YO. And so I was really fortunate to become part of a small group that worked with young people at YO on, how to address these mental health issues that were coming up for young people. And so our partners there were called the PLG, the Peer Leadership Group. And this was a really cool experience for me because the young people actually led this process. They selected an intervention that they thought would be a good fit for young people in Baltimore. The intervention that they chose was called SPARKS, Structured Psychotherapy for Adolescents with Chronic Stress. And SPARKS is a treatment program. It's used in clinics. It's led by trained mental health professionals. It's actually one of the top trauma-informed interventions. And our task was to figure out how were we going to sort of adapt this to be used at the YO centers for young people. And so we would meet with the peer leadership group every week for 9 months, and we adapted it from a treatment program to a prevention program, co-delivered by peer leaders together with an adult facilitator. And this 9-month process was pretty amazing. We went through every session of the curriculum, and the young people said, yeah, that's good. No, this does not feel right for Baltimore. These examples just aren't going to fly. They added more about relationships, but we kept sort of the core components of the intervention and just made it Baltimore friendly. And this was also sort of a great intro to me as to just how incredible young people are as partners. I mean, they would come up with stuff that I would never have thought about doing, and we're able to connect much more with their audience, of course. So I remember at that point, they had examples of before and after photos from when Britney Spears had mental health issues and shaved her head, and they would make all these sort of activities using, media figures and things like that. And so the program was a success. We had promising data. And then we started to think about, well, how could we maybe bring this program into schools before young people have left school and or sort of at this point? Is there a way that we could incorporate it in middle school before that transition to high school to help support young people's success? And so we worked with young people in 6th grade, 7th grade, 8th grade. We got their feedback. At first, they were like not impressed with the intervention. It was because it was for older adolescents and they thought it was boring. We needed more activities. So we went back and forth and we developed it and adapted it further for schools. And then I was fortunate to get funding so I could do some piloting of this program. It improved academic performance. Teachers were seeing a difference. And so we were able to get larger scale funding to do a trial in 29 different schools in Baltimore. And at the same time, I was able to sort of come full circle and come into PopFam as well as mental health. I'm 50-50 and lead the Center for Adolescent Health that had started off all of this work. And we were fortunate to find that the intervention actually reduced depression, anxiety, trauma symptoms, and behavior problems for 8th graders transitioning into high school. So our next task is we're trying to get funding now to really implement this sustainably in schools. So I wanted to share this story just to give a sense of the potential for long-term partnerships and growing things that can actually live on in the communities that we serve, and also a plug for working with young people who are fantastic.
Tamar, thanks so much. I love the theme of partnerships and working with youth, but also that ideas start small and they grow to be amazing things. So for all of you who are new to PopFam, keep all those ideas coming because your ideas are really the future of where we're going to lead in public health. So thanks again for sharing. I'm going to invite Saifuddin Ahmed to come up and say hello.
Sure. Okay, every time I look at you, I go back to 1971. I came here in 1991. Okay, 1991 I came here, and as a student, just like you. In fact, I was sitting almost like this way, and I simply recollect that day when I first came. And I liked this place so much, I never left. Okay, I'm still here, as you can see. And very interestingly, probably, I don't know whether you're really aware of that issue or not, this department is consisted of 2 departments, population dynamics and maternal and childhood. So I used to belong to that population. I did my PhD from the population dynamics department. It was a small department focused on demography. And when I joined as a faculty, I became so much hooked with the teaching and so much fascinated with the teaching that I started teaching 6 courses. Can you believe it? Okay. But in 2 campuses. We have another campus in Washington, D.C., in that campus, and over here. So the professor I was working with, and I was a very junior, you can imagine, when I joined in 1997, 98, around that period of time. Okay, so the professor called me and asked me, and he's a very famous professor, okay, that what do you want to be, a researcher or a teacher? I said, I want to be both. I want to be a teacher and I want to be a researcher. He said, no, you cannot do. You either become a researcher or become a teacher. So that was very fascinating to me. How come in the Hopkins you become either a teacher or become a professor? Okay. So the message was very clear that this is a research institution, a research university. You focus on research, not on teaching. But I completely ignored that message and essentially become independent. And that basically led me to here. And very interestingly, some of you may know that my work primarily on the women's and children's health, And most of my publications, I started with the family planning. I'm originally from Bangladesh. My background is a physician. I did PhD in demography with minor in epidemiology, because at that time, the feeling was in the population dynamics. This is not a core department. So you must have 1 degree, sub-degree from a core department, either from AP, biostats, sociology, or economics. You have to select one of the 4. So I take AP. But interestingly, I started teaching survey methodology course. And that was interesting in the sense that when I joined the department, I was thrown a challenge, and that challenge was what course I'm going to teach, because everybody is teaching a course, right? Every professor was already teaching a course. So I have to find out a gap which is nobody's teaching. And I find that my dissertation was a large survey analysis. And essentially, I started teaching that course. And biostatistics really find it to be fascinating that I'm teaching a biostatistics course. And asked me, why don't you join biostatistics department as a co-faculty? So I've done that. But that is the positive side and the negative side. Positive side is that probably helped me in surviving Hopkins. But at the same time, I have been identified as a statistician, which I really hate. Okay? But again, my fascination for this statistics really continued, and I still love this methodology, and all my work has been, as I said, primarily on maternal child family planning, and probably I touched everything on this area, okay? But when I really look back, I really don't find that I do have that many stories to tell you. So I always find out someone who has a really exciting story. So I decided to talk about John Smith. Okay. We can think about the Wealth of Nations, Adam Smith, and he's considered as a father of economics, modern economics. He wrote a book, Wealth of Nations, that has almost like 1,200 pages. And he essentially popularized the term invisible hands. Okay, this is known as the most iconic metaphor in economics, invisible hands. In that book of 1,200 pages, and with the words of around 562,000 words, he mentioned this thing only once, not twice, only once invisible hands was mentioned. But that really very fascinated to me, that how come only once mentioned, but it has become iconic, almost like the book was written in 1776 when USA became independent. So that really fascinates me in the sense that you do not need to do too many things. Just do one thing that will make your life really valuable and meaningful. And that, I think, is the most critical things I always learn. To do one thing that is critical, that is really meaningful, that will help you, and that will help the world, and that will help the universe and the humankind. Thank you.
So you'll notice another theme among our faculty, which is a passion for learning and a passion for teaching. And I'm often showing up in Saifuddin's office for his counsel. So hopefully you all will as well. I'm going to invite Kristin Bevilacqua to say hello.
Hi, everyone. I'm Kristin. I know a lot of you from advising in classes, but it's nice to see the rest of you. I'm maybe the most junior faculty in the department, so I don't have like that later project stuff to talk about. So I wanted to talk a little bit about how I started to become interested in public health and sort of a formative experience I had in college. But I really got interested in public health in high school when I read Mountains Beyond Mountains by Tracy Kidder, which is about Dr. Paul Farmer. And then I started to read Paul Farmer's work, and I thought this is really sort of a name for what I had been interested in for a long time. So I ended up studying public health in college, and I sort of, any volunteer or work stuff that I could do that was related to public health, I sort of jumped at. And one summer I had the opportunity to move to Ecuador, or to work in Ecuador for a few months. with children who were living with HIV. So they were all HIV positive, and they were living in, like, we wouldn't call it an orphanage here, it was sort of a group home. But at that time, this is 2011, HIV was really stigmatized in Ecuador. It may still be, I don't really know exactly what it looks like, but it was sort of this clandestine orphanage where no one really outside of who worked there knew that they had HIV. So on our weekends, we would sort of travel around Ecuador, and I had lived there previously, so I had some experience or knew where I was. And we ended up taking what would become sort of an ill-advised trip to some local natural hot springs, where I promptly got very sick. So within a few days, I had an ear infection, and it became sort of this, serious illness. So I went to a local doctor, and they gave me antibiotics, and nothing really worked. And I was getting like really sick. And the man who ran this home, he was a Franciscan friar, and he was like so calm. And I was like, I'm not calm right now. Like, something not good is going on. So he said, okay, we'll drive to Quito. We'll take you to Quito to see, another doctor. And one of the kids who was living there at the time was like, I want to ride along. So I'm really sick, like 104 fever, like chills, violently ill. And if you know me, you know that I'm sound sensitive. I'm sure there's other people here, but I don't like certain sounds. And especially if I'm not feeling well, it's like, you just want quiet, right? So we get in the car, and I'm, again, like, I cannot say this enough. I have a multi-drug resistant bacterial infection. And this boy comes along in the car. For him, it's just kind of like this fun trip. We're going to Quito, and he's playing music. Again, 2011. This isn't like a nice iPhone with like good sound quality. He is like blasting music out of like, I don't even, like an MP3 player. It was horrendous. And I'm sitting there like really thinking like, this is the end for me. Like, this is not good, but simultaneously so irritated by this music. And I'm not going to say anything, like, he's just a kid, whatever. And I went to the doctor, and I got a lovely shot of penicillin, where they shoot penicillin, and slowly started to feel better. And I remember sort of like reflecting back on that a few days later when I felt like I was going to make it out of Ecuador alive, and thinking like, actually, that's pretty cool. Like, this kid has HIV. He's living with HIV, but because of antiretrovirals that they had access to, he was fine. And he was like totally cool, just blasting music in my face while I'm really, really ill. And also sitting next to me, right? So if you think about like maybe 20 years earlier, that would have been a really dangerous situation for someone who was living with HIV. So all this to say, it feels like a really scary time in public health right now. And I think it is a really scary time, but we've had scary times before. Just thinking about like the withholding of funds, and specifically related to this story, Reagan very famously withheld funds from the WHO right at the start of the HIV clinic or HIV epidemic, which really sort of set that science back many, many years. So it just sort of all made me think about how, even though these are difficult times, public health we're a resilient field. And we are public health, like in this room, it's not like this sort of faceless entity. So it's up to us to be resilient, and just thinking about like this new generation coming in and sort of having this focus of like, okay, they're not great right now, and they've not been great in the past, but you can sit next to an HIV positive child with a very dangerous infection, and that person can be okay because of public health and because of the advancements that we've made. So yeah, that's my story. Thanks, everyone.
So, love the theme of resilience coming back. My bottom is feeling it for the penicillin shot, having had many of those as a kid. So as soon as you said that, I had vivid images. Joining us online next is Dr. Carolina Cardona.
Hi everyone, can you hear me well?
Yeah, I can hear
you. Yeah.
Perfect, thank you. Hi everyone, I'm Carolina. I am an assistant scientist in the department, and I also had the pleasure of completing my PhD in PopFem and graduating back in 2022. I am very sorry that I'm not able to be there today in person. I had planned to do so, but then one of my meetings got delayed, and then I realized that I wouldn't have enough time to get to Baltimore on time, so apologies for that. So a little bit about me. I am a health economist by training, and my area of research is focused on understanding women's sexual and reproductive health behaviors and how these are interrelated with economic development. Today, we're sharing stories of what brings us to this building. And as I was thinking about this question, I couldn't stop to think that I first came to Hopkins 10 years ago as a master's student, and like many of you here today. And the story that I want to share is what brought me to Hopkins back in 2015. And one of the reasons of why I wanted to come to Hopkins was because I wanted to get a better understanding and gain knowledge that would help me understand the relationship between poverty and health, particularly those aspects affecting child health. Now, this desire to have a better understanding about this relationship between poverty and health was informed by my upbringing in Bolivia. And one of the many stories that influenced this curiosity was a story that I remember very well, that it would happen around the holidays during Christmas time, that many families from their rural areas or the rural communities in Bolivia would come during the holidays to the city in search of solidarity from people looking for food and looking for stock-ups before they would go back to their rural communities. And what I thought was interesting is that these families were not just coming from the outskirts of the city or rural areas that are close to the city. They would come from faraway distances, mainly from those communities located in the Andean region. And also something that I remember very vividly is that these families would always come with many children, and then they would also seek for healthcare. And it was interesting as well that the families were mainly led by women, and they were the ones leading their communities to come to the city in search for, again, support. And then I also remember that I would interact very closely with these families because my grandmother used to organize every year a set of activities to support these families. So seeing this every year would always left me thinking what it is that we can do as a society to help these families and enhance the well-being of the families that were forced to move from their rural communities to the city in order to get some support. Fast forward, as an undergrad student, I found that there was this area of study called economic development, and I was actually very excited to hear Saifuddin talk about Adam Smith. And when I was studying economics, I learned that health is a very important aspect of it. And it's a very important aspect of economic development that can also help us alleviate poverty, which it grew my curiosity and pushed me to come to Hopkins here 10 years ago. Now, this is just this is a brief story that motivates my wantedness to come to Hopkins here 10 years ago, but it also continues to motivate the current work that I do. And most of the work that I do in the department is focused in understanding this relationship between health, particularly women's health, and how it is interrelated with economic development in the context of low and middle income countries. So if any of you has a similar interest and wants to have a longer conversation about these topics, I am more than excited to talk with some of the students here. And you can always send me an email and we can coordinate a meeting, and my door is always open. So, and welcome to Hopkins, and I hope that you have a fantastic academic year ahead. Thank you.
Thanks so much, Carolina. I love hearing the stories because the work that we do is so personal and what motivates us. And I'm looking at Susan Gross because I have a feeling I know what story you might tell, which is also deeply personal and very motivating. And I think what you'll hear in our department is, some of us work globally and domestically, some of us work primarily globally, some of us work primarily domestically, but many of the themes are shared across our work. So welcome.
Good afternoon. I'm Susan Gross. I'm an associate practice professor here in PopFat. So just a little background. I actually came to Hopkins in 1991 as a doctoral student in the Department of Maternal and Child Health. So before the merge, I was in MCH. And I had been working before I came here on projects related to breastfeeding. And when I came here, Dr. David Page, who was the former director of the Johns Hopkins WIC program, which now I'm director, but he was doing a project on a pilot study for breastfeeding peer counselors, and I got to be a part of that project, which is very exciting. So I was very excited about breastfeeding. When I finished my PhD, I went on to continue to work with David on breastfeeding projects, but when I had my family, I was excited to breastfeed my own kids. And actually, before I came here, I was at the National Center for Education and Maternal and Child Health at Georgetown, and I did a report on a follow-up to the Surgeon General's report on breastfeeding and lactation. And so I do a lot about policies, but all of a sudden I was the one breastfeeding. So this is where it gets personal. And this is how what we do in public health also can apply to our own lives. So when my son was 3 months old, and this was in 2000, I was in Toys R Us, which is a store for kids. And yeah, it's no longer around, but it was a store for kids. And there was a lot of toys, and he was hungry. So I sat down on the only bench I could find and started to nurse. And he was covered. And the manager came up to me and said, "I'm sorry, ma'am, this is a store for kids, and they don't need to see that." And I was like thrown, because in my previous research, I knew there were lots of states that had these public, breastfeeding public laws that not to restrict women. And I was like, this is illegal what you're doing. You can't tell people to leave the store. And he's like, sorry, you need to leave. And well, first he offered me the bathroom. He said, well, you can go to the bathroom and nurse. And I was like, would you feed your kids in the bathroom? I was like, no, I'm not going to the bathroom. And Stephen was hungry, so I went to my car and I fed him. But I called my husband and I said, can you believe this happened? This is illegal. And then I started writing letters. I wrote letters to Toys R Us. I wrote letters to all the media, and I also wrote to my state senators. And actually, my state senator, Paula Hollinger, who was a nurse, said to me, actually, there is no law. The only law related to breastfeeding in Maryland is public decency. And I was like, oh, really? So I could have been arrested for breastfeeding in Toys R Us. So I worked with her to get the right to breastfeed in public law established. The first time around, there was a lot of resistance because we had framed it as the mother's right to breastfeed. And there were a lot of people who were saying, oh, you're asking women to be indecent. That there was a lot of resistance, and it didn't get out of committee. But then it came back in 2003, and we framed it as a child's right to the best nutrition they can have. And it passed. And so the right to breastfeeding is on the books. And it told me that one person's voice means a lot. Your personal experience means a lot. It helps if you know what's going on in policy, but it really, it changed my view of how I did my public health research, to be looking at how can we not only show the impact of breastfeeding, but also move policies to improve access to breastfeeding. Thank you. And
so I love that story, because sometimes when you feel like you're amid a sea of a lot of bureaucratic and institutional and other regulations, it just reminds us that one person can and does make a difference. So I hope you'll keep that story in mind as the years unfold. And I think it also speaks to tenacity. And Kristin, you sort of spoke to this. We're all in this for the long haul. So we will have bumps in the road in the next, couple of years, but we'll still be there on the other side. So I'd like to welcome up Dylan Jackson to greet you all.
Hello, everyone. It's good to see you. Good afternoon. I'm Dylan Jackson. I'm an associate professor in the department. And Cynthia just mentioned how we're all in this for the long haul. And my kind of theme today, as I was thinking about what I wanted to say, relates to that, which is we are all allowed to be works in progress. And we need to think about ways that we can give ourselves and others grace as we progress. And so I have two stories that relate to the theme. And one was totally not planned. It happened yesterday, and then it just reinforced that this needs to be my theme. But I have 4 children, and my third child, Desmond, he's 6 years old. And with his brother, he's taking guitar lessons. So I took them last night. It had been a long day. I've had dental procedures. I have pain in my face, all these things, right? And so I don't have like as much patience, but I'm trying. And I'm in these lessons, and he's working on his guitar. And the teacher presented him with this really challenging riff that he had never tried. And you could see the excitement and like, I'm gonna do it and I can get it. And he couldn't quite do it. I mean, I wouldn't be able to do this. This was very hard. And he broke down emotionally in the middle of the lesson. And I said, it's okay, buddy. Like, you're going to be okay. And so finally he talked to me like an hour later about this because he didn't want to talk. And I said, well, what were you feeling? He said, I felt frustrated. I felt sad, and I felt embarrassed. And I said, it's okay. Like, you're allowed to be a work in progress. You're learning, you're growing. And as I was talking about it, I thought, do I apply that to myself? Maybe not. Where does he get this perfectionism from? I don't know where that might be coming from. Maybe a double dose for me and his mom. And as I thought about this, I actually thought about my story of coming to Hopkins. And I know I don't have a lot of time, so I'll be quick, but I came to Hopkins for lots of reasons. But one of the reasons was when I came to interview about 5 years ago, actually 6 years ago, oh my goodness. David Page, who was also mentioned earlier, was the chair of my committee. And David, who's a legend, many of you know, he's retired now, but he showed me that grace to be a work in progress, as so many people continue to do in this department. And he did so by kind of taking me under his wing, even in the moment of the interview, and saying, okay, so I can see that, you're a criminologist, you have a little bit of a different background, but you're talking about public health, but maybe you don't quite know how to frame this and remember your audience. And he kind of gave me a couple tips along the way. And I thought, wow, like, he sees my value, he sees my potential, and he recognizes that I'm a work in progress, and it's okay. It's embraced, it's championed, right? And so that's the space that you're all in. And so take advantage of that, exude that within your relationships, with your classmates, with your teachers, with your friends and your communities. And I think that we can get through this tough time we're in, right? Be positive, be energetic, and be kind and gracious with people, because we're all works in progress. And that's what I wanted to share. Thanks.
I love the theme of being a work in progress, so I'm right there with you. I'm going to invite Lilly up to share with you a little bit about her story. So welcome, Anne.
Hi, my name is Anne, as Cynthia just said. I'm a senior research associate in our department. I work with the Early Childhood Services Research Program team. It is a great team, great work. Our acronym is a mess, and we do need to work on that, Cynthia. Before I get to my story, just some things you should know about me. I am a returned Peace Corps volunteer. I served in South Africa for 2 years in 2 schools. I am a child of this POP family. I have my MSPH degree in child health and child development. After I finished my degree, I went to Baltimore City Schools and worked as a program evaluator for 2 years in the central office. And then I came back here in 2015 as a data analyst. And since that time, I've kind of worked my way up through the ranks. And I now manage a great team of 5 people. Alex, Alexis, Joanna, Sarah, Stephanie, and we all work on projects based in New Jersey. New Jersey, yes, it is the most densely populated state, as you may recall. Maybe you didn't know that before in trivia, but you know it now. So New Jersey, very random. That's a story for another time. It's a story about the incredible gumption of Ann Duggan. But basically, Ann Duggan gave us this incredible opportunity to collaborate with the state of New Jersey. New Jersey has an incredible system to support pregnant people and families with young children. And we have had the opportunity for more than 10 years to support evaluation and quality improvement in that system. our work with, and that's kind of what I wanted to talk about today. So we've supported evaluation in New Jersey for a long time. That's kind of how we started out. For our team, program evaluation is really like the bread and butter of our work. We know that. We know it like the back of our hand. So when we started this work, it was really Ann Duggan and Lori at the helm, learning about this system in New Jersey, and really learning about the central part, which is Connecting New Jersey. That is a system that basically intakes family referrals and then connects families to the services that they want and need. Just to give you a sense of the scope, in 2024, Connecting NJ received referrals from more than 48,000 families in New Jersey. So this is a system that serves a lot of families. But essentially, we started with some evaluation projects, trying to learn about Connecting NJ. How does the system function? What works best? Things like that. As we continued in the work, though, our state partners were like, what about some quality improvement? We know what's happening. Can we make it better? Can we make this service better for families? And so they were like, let's embark on some quality improvement projects. And I think we as a team were super open to this concept, but it was also like, what is quality improvement? How does one do that? Cool name, but what is that? So basically we embarked on this journey in 2019 of learning about quality improvement, learning about the core methods, and learning about what needs to happen for quality improvement to happen. So in collaboration with state partners, local level partners, we embarked on a learning journey, and that required persistence, patience, also incredible humility to say, we don't exactly know what we're doing here. Let's learn together. Let's tap experts. Let's use different resources. And so basically over the course of from 2019 to 2022, we came to agreement on shared measures. We built data dashboards. And since 2022, our local partners have been engaged in quality improvement work on a regular basis. And things are improving in the Connecting NJ system. So I share this story basically because sometimes you may be invited to do something that you know almost nothing about. But it doesn't mean you shouldn't give it a chance. It could really come to fruition. Through collaboration with our state partners, we've done awesome work. I mean, I'm biased, but it's been really neat. It's been neat to see the system improve. And I think it has helped make things better for families in New Jersey, which at the end of the day is the point of the work. Before I conclude my remarks, I need to say that I hope as busy students, you take the time to get to know Baltimore. Annie Smith did a great job last week of highlighting some awesome things about Baltimore. I do just want to highlight the Wren was just named one of the 50 best restaurants in the United States by the New York Times. We have a restaurant scene here. You may need to move around to our different neighborhoods, but there are incredible restaurants in Baltimore. There's a lot to do here. Please give her a chance. She is scrappy, but charming. Lastly, I do teach fundamentals of program evaluation. Some of these names on the screen I do recognize. So hello, I'll see you in the live talk later tomorrow. Thank you, Godspeed, and good luck.
Diane, you are the source of knowledge about many things. She didn't tell you about her passion for extreme sports. So when Anne goes on a bike ride, whoa, how many miles was that? 100 and something, yeah. So when I go on a bike ride, I'm thinking 2 or 3 miles. We are not in the same league, but that's okay. I'm going to invite Dr. Qureshi to come up and say hello.
Hi, everyone. I'm sorry, I'm going to be reading from my phone because I'm incapable of not preparing remarks in advance. I'm Farah Qureshi. I'm an assistant professor and an alum in the department. I completed my master's degree here in 2010 and then loved it so much I came back, a running theme of the day, I see. So I thought about, a long time about what I wanted to share here. And usually I kind of share something about my work and a personal connection to it. But I figure you can kind of read about my work on my faculty profile. So I'm going to share a little bit about just kind of why PopFam is such a special place to me. But first, you kind of need to have a sense of who I am, like outside of all this. So I'm a first generation American. My parents were born in Pakistan, or what was then India. And then they immigrated here in 1970. And when I say here, I mean like here. They immigrated to Baltimore. And so I'm truly a Baltimore kid, like in and out. Me and all 5 of my siblings were born at St. Agnes Hospital in West Baltimore. My dad worked there for like 50 years in the ER. And so Baltimore is like really baked into our family identity. But when I think back about why that is, I think it's interesting because it's not like people were particularly nice to us or like embraced us with open arms. If you know much about Baltimore in the 60s and 70s, you might not be surprised about that. But our journey to being, I would say, accepted in American society was difficult, you know, as it is for many immigrant families. And so in some ways, it's very surprising that I feel so connected to this place. And when I think back about, you know, why that is from a life course perspective as a life course epidemiologist, I think about this idea of like linked lives, right? I'm the 5th of 6th. I'm the second youngest. My sisters were all teenagers when I was growing up. So like I had some of those cultural touchstones that like made me feel connected to this place. But even then, it wasn't easy being a South Asian Muslim in the 1990s and the 2000s. I didn't see myself reflected anywhere in pop culture, except in racist caricatures. And especially after 9/11, it got even worse. That happened when I was in high school. At that point, I started to receive messages that, you know, my kind weren't welcome here. And I even remember my dad having a patient who he had seen for many years, like maybe even 20 years, tell him that after 9/11. I was just thinking, that's crazy. Like you've been here, you've been seeing this man for like 20 years. But suffice it to say, I grew up very much feeling like I didn't belong. And so again, in this context of this cultural backdrop, what is it about this place that grounded me and made me feel like a part of the city? And you may be surprised to hear, although not if you know me, that for me, I think it was really sports. So my family is a big sports family. My dad learned English and connected with his colleagues by talking about the Colts back in the 70s, talking about the Orioles, which were like a dynasty in the 60s and 70s. And we went to games all the time. We went to Orioles games all the time. And it was like a really big part of my childhood. And I think that was a really important thing for me to feel connected to the city, because when I sat in those stands, I wasn't like different. I was a fan. I was a part of the team. Like I was there, you know, I was a part of something bigger than myself. And that idea really extended into school as well as I started to play sports. So when I was a kid, I was a very shy, timid, quiet brown girl who like just felt invisible all the time, except for those brief glimmers of moments when I got to play sports at school. And once in middle school, the varsity volleyball coach saw me and was like, hey, you're tall and you're strong, so you should play our sport. I hadn't played a day in my life, and she plucked me out. My parents never invested any single moment into my athletic like development as a child. And so it was like wild that somebody would see me and be like, hey, I think you should do this. And so she saw something in me, right? And by the time I got to high school, my varsity teams were probably the only place where the very hoity-toity white girls that I went to school with like treated me like I existed. And that was like wild to me, because I wasn't somebody who looked different and had a different sounding name and had like older immigrant parents who did not attend any single parent-teacher conference I ever had because they were always working. I was a part of something bigger. I was a part of a team. So coming back to why we're all here in Pop Fam, I think that's the beautiful thing about our department. Here, you're a part of something bigger than yourself. You're a part of a global coalition to improve the lives of women and children here in the US and across the world. And no matter what you may think, particularly for people who feel like you may not see yourself or your lived experiences reflected in this space, I just want you to rest assured that you are here, you are seen, you belong, and you're the future of our field, and we're really happy to have you here. So with that, I want to say go team, and I hope that you guys have a great start to the year. And if anyone wants to talk to me about literally any major sporting event that occurs anywhere in the world, you can find me in E4624. I'm right there.
Farah, we're so glad to be on your team. So, so great. So we are a community in Pop Fam, and if at any point anyone who's new or continuing the department doesn't feel that way, come see any one of us, and we'll address it and figure out why and what we can do to make it better. So one of the things we are very privileged in our department to have is an array of multidisciplinary talents, as well as faculty from multiple divisions. And so I'm going to invite Dr. Maria Trent to come up and say hello.
Hi, y'all. I have to tell you that I have had a lot of work on the other side, and I thought it was to tell my story and not a story. So I have a long story that I'm not going to tell you today because it would take too long. So my name is Maria Trent. I am one of the Bloomberg Professors of American Health and Adolescent Health, and then also a professor of the School of Medicine and Director Division of Adolescent and Young Adult Medicine in the school. I'm also the Senior Associate Dean for Diversity and Inclusive Excellence for the School of Medicine, which allows me to have very difficult jobs right now. So all of them, and I can talk about why, but I decided that I was going to share with you some other insights today. So I did watch the other ones and they gave you nuggets. So I thought I would focus on those. I am an independent scientist. I really focus on improving sexual and reproductive health outcomes for adolescents and young adults. And the research spans everything from quality improvement to clinical trials to health economic analyses to now we're doing research in the microbial genomic space to try to understand a variety of areas. So I'll just say my first nugget, right, is to always think from an interdisciplinary perspective. Always look for people who are smarter than you, perhaps in other areas, because the collaborative nature, I think, of public health can be very empowering. I will say that, you know, I've been here almost a quarter of a century. And recently I've heard this discussion around how to say no from the current generation, for example, trainees that we have. And I would encourage people to think about how to say yes. And because I think because I've been willing to be adventurous, sometimes just brave, and also to work outside of the typical boundaries of our 9-to-5 work hours, that I have been rewarded with, I think, a wonderful professional experience. And if I had my little slideshow that I like to show our fellows, I have a picture of me in Milan, Italy, with a double stroller in front of my poster. And but it's interesting, you know, when you think about it, you know, my kids have been traveling since they were infants. And so, you know, a couple of years ago, I put my daughter on a plane by herself. She's like, I've got it. She had her bag and she went on. I mean, I was in the airport crying, but it's this whole notion around how there sometimes can be a confluence between your work life and your personal life that's very rich. And I would hate for you to miss out on that because it's been great for me. I trained before I came here at the Harvard School of Public Health and did a fellowship at Boston Children's Hospital. And it was a rough 3 years. So the other thing I want to say is that life happens while you're in graduate school. And I think that that's the other thing that I learned there. I had been there 2 weeks and my mother was diagnosed with breast cancer. And I had to ask my fellowship director if I could travel to New York, because she had come to New York for care, to be with her for surgery. And I was a Southerner in New England and asking for stuff, you know, I was new. And they had a lot of people who were from that region. But consistently, there were other things that happened there. It was just a really gritty time and for me. But I think it prepared me to be here. It prepared me to develop as a scientist. It also allowed me to explore other areas, which I encourage people to do in public health school. As an example, you know, I joined a delegation when I was in public health school with there was also with the business school to go on a delegation to go to Cuba to look at their public health system. And it was really empowering for me at that time in my life. I met a Cuban doctor who like could have been my uncle. And I remember not being great with, I was uncomfortable speaking Spanish despite having 5 years of it. And, but he looked at me like, I know you're not gonna speak English. And so I did, but all the other people in my group didn't know I could speak Spanish. So they were probably talking about me, but But it was really empowering for me. And so after I came back, then I convinced my program director to invest in me going to Dominican Republic because all these patients were picking me out of the book. I guess because I'm Maria. And but I couldn't talk to their parents as well. And I think it was a challenge for me. So even from a social aspect, so I went and did Spanish immersion, lived with a family in Dominican Republic. And so really invested myself in those things. But I had to think out of the box and think about what I needed. So this is a chance for you to hone your professional skills moving forward. I would say that relationships are important. I'm trying to say this really fast. I'm gonna say two of my mentors. One is Lori Zabin, gone too soon, but I was one of the people that she kind of took in, and we did these long readings, and I read all this stuff with her every week for a long time. And then ultimately, she bequeathed her class to me, which is a very popular adolescent sexual reproductive health course. But we taught it together, and then she sort of moved it on, and Ann Burke joined me. But it's been a very powerful learning experience, I think, as a teacher of public health as well. And I think that's a part of it that's really very engaging. I will also say Charlotte Gatos, who's a bench scientist, is another example. I think it broadened my perspective about that interdisciplinary work because it just made it bigger. To work with companies that make new products, because what it means is that I'm able to bring innovation to some of the poorest people in Baltimore to get care that no one else can buy here right now in their healthcare system, because I'm able to try new things through doing randomized trials. The last thing I will say about the life is lifing part of it, and I'll close now, is that I would just have to say, when life gets hard, I think you should lean on other people. Create yourself a network of people here. Life is also hard sometimes for faculty. I can say several years ago, I'll just tell you that my husband died suddenly, and I was raising an 11 and a 14-year-old child. And it was difficult. I couldn't have survived Harvard without him. I couldn't have survived my residency in DC Children's, starting here as a faculty member, a lot of stuff. But what I will say is that adolescents need something special. So whatever you decide to study here, think about the adolescent lens. I was at a meeting with my colleague last week in terms of thinking about the health IT things. They don't even think about how adolescents need to use the electronic health record. They don't, what are the, when you're doing demography, what are you doing with the adolescent cohort? When you think about fertility, their fertility may be shortened here in Baltimore, just think about them. Because I can tell you that when you're trying to do all this public Johns Hopkins professor stuff, and you have these two kids looking at you for direction, I now understand what it's like to suffer loss and to feel trauma and to have to pick people up, teenagers up. It makes me appreciate the patients I care for, the kind of studies I design, how we can involve young people. And I would just say that they're worth our effort in the public health space. They are a target because of the type of things they need. And so I just hope that you will think about them. I will say Baltimore is great. No matter what anyone says about it, it's one of the best places right now for people who are up and coming. It's a data piece. So come take adolescent sexual and reproductive health. We'd love to see you in 4th term. It's not a sales pitch.
Thanks so much, Maria. Anyone who comes after her is welcome to make their pitch as well for other ends of the life course. It's okay. Anaise, I'm going to invite you up to say hello.
Hi, everybody. I'm Anaise Williams. I'm an assistant scientist in the department, and I'm at the Center for Global Women's Health and Gender Equity with Michelle Decker and Shannon Wood and others. I will put a pitch in for international perspectives on women, gender, and health. I'm just following. But yeah, what we do at the center, we work on gender equity broadly and gender-based violence prevention. If you haven't already come by our suite on the 4th floor, definitely swing by. I'm usually there Monday through Wednesday. But in thinking about I work mostly on intimate partner violence. And when I think about what brought me to gender-based violence, it was really a study I did in 2013 after college. And it was an ethnographic study in Dhaka, Bangladesh. And I was studying postpartum depression. And the sample was women who had given birth in the past 6 months. And I actually, at the time, I didn't know much about gender-based violence. I didn't actually go into the study seeking to ask about it. But unfortunately, unfortunately, women really wanted to talk about it. This was really open-ended narrative kind of data collection. So they were able to kind of discuss what their challenges were. And so they spoke a lot about partner violence in relation to that post-birth period. And that was really, really eye-opening for me. So this really motivated me to try to understand GBV and more deeply the gender norms that really drive it. I also had a baby this past December, which totally rocked my world in great ways and also challenges. And, thankfully I am in a safe partnership. But the experience of, being in this postpartum period has definitely provided me insight into sort of family dynamics, challenges that families face in the postpartum period and beyond. And, there's just a lot of new things to navigate with your partner. And sometimes it can feel like a whole new relationship, and both very beautiful, but definitely different. So it's really interesting for me to kind of think back to that first public health study that I did so many years ago now, being in the life stage, that I'm in, and given those women were in that postpartum period that I now find myself in, and I'm realizing like, wow, I really understand their experiences a little bit better now that I'm kind of in this particular life stage. So I wanted to share this because, all of you will be working on really important and oftentimes really tough topics. And sometimes it'll be about individuals, but often in this department, we focus on families and couples and interpersonal relationships. And we all have those in our lives, right? And we all have very complex relationships in our lives that we have to navigate. So it's useful to kind of reflect on ways that we can relate to the people in our public health studies or projects. Also thinking about, of course, the differences. I'm trying to think a little bit more about this relationship in my work. And we talk a lot about this in more qualitative research. I do global health, mostly quantitative, but I still think the way that we sort of interpret our findings and people's experiences are so embedded in our own experiences, right? And especially the life stage that we're in. And this is particularly the case for work that we do in POP-FAM because it's so personal, and we, interpersonal relations are so personal. So I encourage you to find ways to relate to the people that you study, whether that's if you're doing data collection or even just reading about certain populations in your courses. Because it's actually, I know grad school is so busy, but doing that in a way that reflects on your own life, your own experiences, finding the time to do that will really help you kind of think about your values and what you're passionate about and what you want to contribute to. And grad school is such a great time to do that. So all to say, I'm motivated to come to work every day because I truly do care about people having healthy relationships, and what a privilege it is for us to work on people's health, right? And the well-being of families, especially in this day and age. So all of us are in a great place, and I'm wishing you the best school year ahead, and my door is always open, and it's great to see you all.
So thanks, Anaise. I know when people say my door is always open, everyone thinks, yeah, that's not really true. It is really true, because when I walk by, I say hello and we have a conversation, which is great. So speaking of door always open, I'm going to invite Shannon Wood to say hi.
Hi, everyone. I'll try to keep this short because I think we have one more after me. My name's Shannon Wood. I'm an assistant professor in the department, and I want to piggyback a little bit on what Dylan was saying today, just about being imperfect and having an idea of what you want to do, but kind of a curvy path to get there. So when I started college, I was just reflecting back on this. I think I had 3 different majors. It changed quite often. We didn't have something called public health, but I ultimately ended up with a major called medical humanities, which was basically for people who were interested in medicine, but had no idea what they wanted to do. And so I first learned about public health when I went on a trip to Kenya with some of my professors, and I needed to do an honors thesis. I did it very vaguely on determinants of contraceptive use in rural Western Kenya. And the findings of my study were that I didn't find anything associated with contraceptive use except for experiencing sexual violence in the last month. And we learned that over half of women had experienced sexual violence. And that to me was just really staggering. I knew nothing about this. So naturally, I tried to find out a little bit more. I went off and did a master's in reproductive and sexual health research, really dug into violence, trying to understand upstream factors influencing sexual and reproductive health. But when I graduated from a master's program, I could not find a job. And I think it's really important for a faculty member to actually say that to students because it's a pretty rough time in public health. I had to piece together a number of different things, working on different projects, but I ultimately landed a role that was definitely not my dream job. But it was at the National Cancer Institute working as an epi analyst there. And this job, it has hardly anything to do with what I do now, but it really shaped me as a researcher and as a person. I had excellent mentorship, so definitely look for that. If it's something that you're not interested in, or even just tangentially interested in, but you know that someone is amazing to work with, they can provide you hands-on mentorship. They can dig into your code and teach you all of the things that you possibly need to know. They're a really wonderful person to work with. And so I did this job for 2 years. I grew a lot. I learned a ton. And then I came to Johns Hopkins for a PhD, and like many faculty member here, I just never left because I loved it so much. But I reflect often on my kind of pivot away from contraceptive use, intimate partner violence. That's really where my research is now, bridging violence against women and women's sexual and reproductive health. But I think it's important to think about those different curves that you can take along the way. It's important to gather all the skills that you think that you'll need in your toolbox. Really take some strong methods training while you're here. Again, I know it's a tricky time in public health, and I have students talking to me about this all the time. But really think about those relationships and those skills and that North Star that will keep you going to where you want to go along the way. So thank you.
Great. So we have one more who's going to share with you sort of their story, but I love your ending with the North Star. So if at any point along the course of this year, in the future, any of you are finding a little hazy to see your North Star, again, come see any one of us. Linnea, welcome.
Hi, everyone. I'm Linnea Zimmerman. I am the last one because virtue of my name, Zimmerman. But I actually really enjoy being the last one at these because I get to like pull from some of the other stories. Before I do that, I'm also the area of interest lead, focal area of interest for women's, sexual and reproductive health. So for those of you who are WSRH, if you have questions, concerns, anything you want to talk about for the area of interest, my room, I just moved. It is now E4146. And I'm happy to set up a time to talk. And then I also teach 2 courses, social and economic aspects of fertility and family planning policies and programs, both very pertinent and of the moment. So I came to Hopkins in 2009. So one of the lessons here is that for those of you who think that you are going to be here and leave and go spread your wings, look around you. We're all still here. So find a house that you want to buy and stick to it. Okay, so I came in 2009. I came like dedicated to understanding contraceptive use. I was like, contraceptive use is it. It's the magic bullet. It gives women and other, just everyone this opportunity to plan your families and decide, you're gonna go on your path, you're gonna get your education, you're gonna find that partner, you're gonna start your job, and then when you're ready, you're gonna have a kid. A lot more complicated than that. So there you've heard the message of, you might not know what you're interested in. Very true. You also might have a plan for your life. And contraception is great. It is an amazing tool. And it does give people a lot of options. But the other thing that I have learned since I've been here is this windy path that we go through. It's for your interests. It's for your life. So I was a, do as I say and as I do kind of person. I was very, it's like get emotional about this, even though it's been a long time. Last year I got people to cry, but Celia's not here this year, so I can't tell. So I got my degree. I was here, I was working, I found a wonderful partner. We got married during COVID. Don't do it. And get married if you want to, but not during an epidemic. And we started to, get to the business of making children, and it didn't work. And I know, okay, 6 months, I'm over 35. If it doesn't work in 6 months, you go find a doctor. So we did. We went to an infertility specialist, did some tests, something was wrong, something was wrong, something was wrong. Within 6 weeks, I was diagnosed with uterine cancer. And 4 weeks later, I had a hysterectomy. So I lost my uterus and my fallopian tubes, but I got to keep my ovaries, which was good because we could go through IVF. And we are very lucky. I have a great job. My husband has a great job. We were able to find a gestational carrier. And last time when I told this story 2 years ago, I got to announce to everyone that we were pregnant with our first child. He's a boy. He is wonderful. He looks like a Pixar character. He's very chubby, he has huge eyes, great hair. This time I get to stand up here and tell you that actually we are expecting our second child. Thank you. Salam, I hope that Salam is like cheering in there. But I have learned from that as much as contraception is an amazing public health good, it is one part of a coin. And if we are really dedicated to the idea of allowing people to have choice and reproductive choice, we have to be invested in the whole spectrum. And so for some people at the right time in the right place, contraception is the right answer. We also have to acknowledge that for some people, it's not at any point. Maybe there are people who do want to become pregnant and maybe their choice and their circumstances aren't what I would do, but that doesn't matter because it's their choice. And then we also have to acknowledge that for some people, contraception is not and will never be the answer because some people want to have a child and they aren't able to. And so that to me is what keeps me coming back, is understanding this, that public health is more than what we think it should be. It's what people themselves think it should be, and that we should be here to support them in that full journey. And I'm getting emotional again. Anyway, come talk to me anytime. Congratulations.
So I can't think of a better ending than to emphasize family is in our department name, and we take it really seriously. So excited for you, and so excited for all of you who are joining the department and back in the department this year. We're going to have a great year ahead. We're going to have lots of curves, as you heard, but we're works in progress, and I'm going to pick up on that theme during the course of the year, and we'll look forward to seeing you all at many more activities in the weeks and months to come. So thanks so much to everyone for being here today.